Hi guys, it's Kathleen on another lecture on management of heart failure. So heart failure is an inability to pump sufficient amounts of blood to meet the body's physiological needs. It's really important that this is not a diagnosis, but instead a syndrome. It's characterized by shortness of breath, fluid retention, fatigue. Patients often have left-sided heart failure. Know that you can have both systolic and diastolic function. You can have left-sided heart failure and right-sided heart failure, or systolic or diastolic dysfunction. Risk factors for heart failure are diabetes, metabolic syndrome, advanced age, male gender, African American, coronary artery disease, MI, hypertension. Remember that with the lecture, that's a leading cause. One of the leading causes of heart failure is hypertension. So it's really important as primary care providers that we're good at managing hypertension. It becomes preventative for heart failure. Smoking, obesity, increased stress, increased sodium diet, lack of medication adherence is a risk factor if they're not taking the cholesterol, their hypertension meds. ETOH excess, sleep apnea, and chemo and radiation are also a risk factor. There are chemo agents that can cause injury to the myocardium, which can eventually lead to heart failure. Characteristics of systolic, we talk about that left ventricle not being able to pump out, and normal ejection fracture is never 100% ejection fracture. A normal ejection fracture 65 to 56, I'd say, maybe 60 to 65 is a normal ejection fracture. Impaired left ventricular function with systolic dysfunction, EF is less than 35 to 40%. You have decreased stroke volume, decreased cardiac output. You have an enlarged, dilated ventricle, and that's caused by the increase in stretch due to a failing left ventricle. You have increased end diastolic pressure, which over time creates a larger ventricle, which, according to Stalling's law, that stretch becomes inefficient. It doesn't contract as well, and you get an increased end diastolic pressure. With diastolic heart failure, the diagnosis of diastolic is more challenging than systolic. Patients have preserved left ventricular function. It's often more common in women. And so, again, the diagnosis of diastolic heart failure is more challenging than the diagnosis of systolic heart failure. You need to exclude causes that are non-cardiac of symptoms that are suggestive of heart failure. So, make sure this isn't pulmonary or something else before, because you have that normal ejection fracture. A lot of times you're going down other avenues because they have a normal ejection fracture. With diastolic dysfunction, the ventricle has an inability of the heart to relax and fill during diastole. You have increased ventricular stiffness, impaired ventricular filling, you have increased end diastolic pressure, you have decreased compliance, and basically failure of cardiac output to rise with exertion. Diastolic dysfunction is often, again, caused by uncontrolled hypertension. And again, with diastolic dysfunction, you can have an ejection fracture of 50%, a normal EF. The diagnosis of systolic heart failure, normally you hear an S3, which is due to abnormal filling of the dilated chamber. Know that an extra heart sound is not normal, and S3 is not normal. It comes right after S2, and it's not normal. It's almost like an extra sound that you hear, and that's due to the actual volume that is occurring in that left ventricle. The volume is not the normal volume that's normally in that ventricle. The physics of it all is it creates another sound, another pressure sound that you're getting, because there's too much pressure in that dilated chamber, and it creates an extra sound. Chest x-ray is really important. You're going to see an enlarged heart. You also could see pulmonary congestion on chest x-ray. Oftentimes there'll be Q waves on an EKG telling us this person has had an old MI. In diastolic heart failure, oftentimes you hear an S4, which comes right before S1, and that's due to atrial contraction into a stiff ventricle. Pulmonary congestion on chest x-ray, and left ventricular hypertrophy on EKG, which, remember I said that diastolic heart failure oftentimes is caused by uncontrolled hypertension over the years. So etiology of systolic heart failure is ischemic heart disease, MI, CAD, diabetes, dilated cardiomyopathy, prolonged uncontrolled hypertension, and valvular heart disease. Diastolic heart failure oftentimes is due to ischemic heart disease, hypertension, CAD, hypertrophic cardiomyopathy, and this occurs when the heart muscle cells, they enlarge and they cause the walls of the ventricles, usually the left ventricle, to thicken. Despite this thickening, the ventricular size often remains normal. However, the thickening may block the blood flow out of the ventricle. If this opens, the condition is called obstructive hypertrophic cardiomyopathy, and you oftentimes see that with diastolic heart failure. Also, diastolic heart failure is due to constrictive pericarditis, advanced age. Again, it's most common in women, obesity, and aortic stenosis, because that aortic valve during systole is open, stenotic, and causes more pressure during diastole. And that's where you have a lot of times diastolic heart failure. Some different symptoms with right-sided heart failure versus left-sided heart failure. You're going to have symptoms of venous congestion, abdominal symptoms, nausea, vomiting, bloating, constipation, pain, decreased appetite. You'll have elevated liver function tests due to the congestion. Left-sided heart failure, you have symptoms of pulmonary congestion, pulmonary symptoms like dyspnea on exertion, paroxysmal nocturnal dyspnea, orthopnea, wheezing, tachypnea, and cough. And it's really important that you document this in your HPI. You know, are they having any of this? Because as you're coding, and you'll have your own coder. Sometimes you'll be your own coder. Thank God I don't have to code my own notes. But I know, like in primary care, a lot of them have to code their own notes. So you really have to be very good at making sure that the diagnosis that you have symptoms that coincide with the diagnosis that you've come up with your patient. For example, if a patient comes in for shortness of breath, you know, you write your HPI, patients had shortness of breath for the last 3 to 4 days. They've reported to have gained 3 pounds in the last 2 weeks. They cannot sleep lying flat in the bed for the last 3 days. They have to sleep in the recliner. They're also complaining of a cough, They also have nausea, vomiting. They have +2 pitting edema. It's stuff like that that needs to be in the HPI. That's very important with patients that have congestive heart failure. Common symptoms of heart failure are weakness, fatigue, confusion, decreased mental status, insomnia, decreased exercise tolerance. Patients complain of a headache. They can go into a coma. Oftentimes they have paroxysmal nocturnal dyspnea, which require them to be unable to lie flat. They have declining functional status. They can't do what they used to do because their heart failure is progressing. You know, when we talk about decreased mental status, or a lot of times they don't have the perfusion to the brain that they normally had, and that you have to take that in consideration when you're doing a lot of teaching. Really involve the family, which I know most of you know how to do that already, but you might be doing this individual teaching in your office, or you might have a medical assistant that helps you with the more detailed teaching, but this is really key with heart failure. There's a lot of self-care that's involved, that you have to involve the family, because these patients are very sick and they need as much support that they can get. And that includes family, because most of the family are not medical. So these symptoms that I'm talking about, they are found in both right and left-sided heart failure. So different signs of heart failure. The right-sided heart failure, you have fluid retention, weight gain, peripheral edema, JVD, hepatojugular reflux, hepatic ascites, enlarged spleen from the right-sided congestion. With left-sided failure, you have bilateral pulmonary rales, S3 gallop. You can have chain stokes, respirations, pleural effusion, and pulmonary edema. Abdominal exam is very important with patients in congestive heart failure. Common signs of heart failure are tachycardia, cardiomegaly, cyanosis, oliguria, nocturia, and peripheral edema. And oliguria is reduced excretion of urine, and nocturia is urine at night, especially excessive urine at night. Modified Framingham criteria, you need two major, one major, and two minor for diagnosis. So major criteria would be paroxysmal nocturnal dyspnea, orthopnea, elevated JVD, pulmonary rales, cardiomegaly on chest x-ray, acute pulmonary edema, S3 gallop, increased central venous pressure, and hepatojugular reflux, which basically you as the provider, with the hepatojugular reflux, you as the provider press firmly over either the right upper quadrant of the abdomen, over the liver, or over the center of the abdomen for 10 to 60 seconds with a pressure about 20 to 35 millimeters of mercury. And while doing this, you're observing the internal jugular vein in the neck, and also observing to be sure the patient does not perform a Valsalva maneuver. On an otherwise healthy person like yourself, the jugular venous pressure should remain constant or temporarily rise with each heartbeat or two before returning to normal. This is a negative result, which would indicate a lack of swelling of the jugular vein. A positive result is defined as either sustained rise in JVP of at least 4 centimeters or more, or a fall of 4 centimeters or more after the examiner releases pressure. This actual exam technique has reported sensitivity between 24 to 72%, and the specificity is 96 to 93%. So the minor criteria, weight loss of greater than 4.5 kilograms in response to treatment. So that means patients, they've been diuresed and they've lost greater than 4.5 kilograms in response to the diuresis. That's a major criteria. And minor criteria for the diagnosis of heart failure are bilateral ankle edema, bilateral leg edema, a nocturnal cough, dyspnea on exertion, hepatomegaly, enlarged liver, pleural effusion, tachycardia, and a decrease in vital capacity by 1/3 from the maximum recorded. Have their vital capacity at the pulmonologist have shown a significant decrease. Staging system for heart failure, there's stage A, B, C, D. Stage A, the patients that are at high risk for developing heart failure but have no structural disorder of the heart. And stage B are patients with structural disorder of the heart but have never developed symptoms. Stage C are patients with past or current symptoms of heart failure associated with underlying structural heart disease. And stage D are patients with end-stage disease who require extra specialized treatments to survive. There's also a New York Heart Association functional classification. These are descriptive findings in patients with cardiac disease. You have functional class 1, which is no physical limitation on activity. Functional class 2 is symptomatic with moderate activity. Functional class 3 are symptomatic with mild activity, and class 4 is symptomatic at rest. On physical exam, it's very important to do a very thorough physical exam. Vital signs, weight, eye exam, neck exam. You want to test their thyroid, any carotid bruits, JVD. Cardiovascular, you want to assess their rhythm and rate, assess for extra heart sounds, also any murmurs, and also document their PMI and where you heard their PMI anatomically. Respiratory, you're assessing for any adventitious sounds. The abdomen, you're assessing for any bruits, orgomegaly, or ascites in the abdomen. Extremities, you want to assess the posterior dorsalis pedis or posterior tibialis pulses, any edema, capillary refill, and mental status exam, as well as a complete neuro exam. Laboratory and diagnostic tests. We have the BNP, which is the beta natriuretic peptide BNP. This laboratory study can help identify heart failure as the diagnosis if someone presents with dyspnea and was unsure of the diagnosis. When serum levels of BNP are less than 100, the diagnosis of CHF is unlikely. Serum levels of BNP that range from 100 to 500 is probable cause for CHF, and BNP levels that are greater than 500 are considered to be definitely consistent with the diagnosis of heart failure. Non-heart failure conditions such as a PE, renal failure, acute coronary syndrome may cause elevated BNPs, so we have to take that into consideration too. The use of BNP for guided therapy in chronic heart failure for acutely compensated heart failure is not really well established, so you'll see that oftentimes in trending in the hospital, but some cardiologists won't use that as a guided therapy, but know that some people do. But it doesn't have a lot of evidence behind it. But it's, I think, category C in the new guidelines. Cardiac enzymes can be used if their patients are coming in, they have shortness of breath. Want to make sure that this is an ischemia that's causing the shortness of breath or any injuries. Decreased sed rate can help to diagnose early mild to moderate heart failure. I don't see that used a lot, and I don't see any new evidence, but know that sometimes you'll see providers or cardiologists draw that. Elevated creatinine levels and dilutional hyponatremia, that's a low sodium, may be observed in severe cases of heart failure. When you see that, that's a really poor prognosis when they have dilutional hyponatremia. Bilirubin can be elevated with congestive liver. Both anemia and high RDW associated with a poor prognosis of heart failure as well. Other diagnostic tests are TSH. You want to make sure that this isn't a cause, is the thyroid have anything to do with congestive heart failure or tachycardia that's presenting with maybe pneumonia, CHF, or pulmonary edema. Diagnostic tests, you want to get a chest x-ray, EKG, you want to get an echo, really take a look at the valves and the estimated ejection fraction and the pressures within the heart. Angiography, that's a cardiac cath, is a gold standard to actually assess coronary arteries. Pharmacological treatment. Treatment is dependent on patient's ejection fraction, volume status, comorbidities. We want to make sure that we avoid or monitor meds that exacerbate heart failure and medication education. Calcium channel blockers for individuals with decreasing or reduced left ventricular ejection fraction. You really want to avoid the use of cardizem and verapamil in patients with systolic dysfunction, as well as nonsteroidals, which actually may increase mortality and have negative inotrope effects as well. Nonsteroidals, the negative inotrope effects, are from the calcium channel blockers, cardizem and verapamil. Also, erythromycin can prolong QT interval, leading to ventricular arrhythmias. So those are meds you want to be careful of, as well as tricyclic antidepressants can depress cardiac function. And nonsteroidals may increase mortality. Those are nonsteroidals. And they can cause worsening heart failure, and that's due to nonsteroidals cause sodium and water retention. ACE inhibitors are treatment of choice. Very important that patients are on ACE inhibitors if there's no contraindication. This should be considered a priority in all patients with congestive heart failure unless absolutely contraindicated. This has shown an increase in survival, improve in symptoms, and overall exercise capacity when patients are on ACE inhibitors. And patients who benefit the most are those with systolic heart failure and post-MI. With congestive heart failure, when you have, heart failure, I should say, not congestive heart failure. When you have heart failure, you have a sympathetic, you have a neurohormonal response that is triggered. You have your sympathetic nervous system that wants to try and actually have that ventricles contract to increase perfusion to your body. So you have that. When that occurs, you have potent vasoconstriction from the sympathetic response. You also have the renin, angiotensin, aldosterone system that also is stimulated as well. Both of them trying to get the volume back, get the heart working better, and that's considered a neurohormonal response. ACE inhibitors and beta blockers are used to block that. And why we want to block both of those is because when those neurohormonal responses, the sympathetic and the renin, angiotensin, aldosterone, when both of those are stimulated, what you have when they're both stimulated, you have that heart getting bigger. You have that Frank Starling law of the heart. Over time, the body is not going to be efficient. The heart is going to get bigger and bigger and bigger. And that's why it's important to be on an ACE inhibitor and beta blocker to stop the normal neurohormonal response that occurs with congestive heart failure. So we want to stop that neurohormonal response. We want to get them on beta blockers. We want to get them on ACE inhibitors. And there's also a new drug that I'm going to talk about that's going to replace the ACE inhibitors. And it's showing, it's showing wonderful results. So when we do that, we're actually stopping when you have sympathetic nervous system and the renin-angiotensin-aldosterone system stimulated, it creates the heart getting bigger. It also causes apoptosis within the myocytes of the heart and worsening enlargement of the heart. And it's like that rubber band effect. It keeps on stretching and stretching and stretching until it breaks and it doesn't work anymore. It's similar to that. And when that occurs, that's called a neurohormonal response, and it's not good. So having ACE inhibitors and beta blockers is used to stop the progression. When we stimulate neurohormonal response, we are creating cardiac remodeling of the heart, which causes the heart to get bigger and bigger and bigger. So we want to block that with ACE inhibitors. And ACE inhibitors interfere with the conversion of angiotensin 1 to angiotensin 2, leading to a decreased systemic and pulmonary vascular resistance. This medicine decreases left ventricular pressures, increases cardiac output, and it causes that regression of left ventricular hypertrophy, that cardiac remodeling, and decreases blood pressure. Used in all patients with left ventricular systolic dysfunction and an ejection fraction of less than 40%. Again, it improves the disease progression, just like I talked about, that apoptosis and the cardiac remodeling when you put patients on ACE inhibitors. Some contraindications: you cannot give ACE inhibitors if you have a potassium that's greater than 5.5. Patients that have symptomatic hypertension, pregnancy, they cannot take any history of angioedema with ACE inhibitors, do not prescribe. Any renal insufficiency, you have to watch them very closely, or any renal artery stenosis. So a creatinine greater than 3, you would not give an ACE inhibitor. ACE inhibitors, some of the side effects are cough. That's a big one. Most of the time patients can't be on this medication because of cough, and will switch to an ARB, which is an angiotensin receptor blocker. Renal insufficiency, angioedema, it's not very common, but it does occur with ACE inhibitors. Hypotension, dizziness, fatigue, elevated potassium, and elevated BUN and creatinine. So you have to watch out. You have to have them come back and check, especially elderly, come back and check their BMP to make sure that their kidneys are okay and that what their potassium is as well. You want to start them on low doses and double every 3 to 7 days. You want to monitor blood pressure, renal function, and electrolytes every 1 to 2 weeks after initiation or increase in dose. When stable, you want to monitor renal function and potassium every 3 to 6 months and assess for side effects of cough and angioedema. Other medications are called angiotensin receptor blockers. The mechanism of action interferes with the renin-angiotensin-aldosterone system. It blocks the conversion of angiotensin 2. It blocks vasoconstriction. And these medications used to improve disease progression and improves exercise tolerance. It's used if unable to tolerate ACE inhibitors related to the cough or the angioedema. I'm going to make a note here. You wouldn't want to prescribe an ARB, an angiotensin 2 receptor blocker, if they had angioedema with an ACE inhibitor. You would definitely want to consult and let someone else do that. Contraindications for ARBs are pregnancy, renal artery stenosis, similar to the ACE, serum K greater than 5.5, caution with impaired kidney function, impaired liver function, hypotension, and angioedema with ACE inhibitors. Side effects it can cause a high potassium, hypotension, renal insufficiency, a headache, and cough. Beta blockers, again, they're used to stop the neurohormonal response. This is, again, I'm going to repeat this again. Beta block, the activation of the sympathetic nervous system is one of the main mechanisms responsible for the progression of heart failure. Beta blockers are used in systolic or diastolic heart failure, and they're initiated in hemodynamically stable, compensated patients at low dose and titrated upward slowly. And there's evidence that for titration of the beta blockers, you monitor the heart rate rather than a specific dose. So they can go up to a target dose only if their heart rate is maintained at 60 to 70. So, for example, carvedilol, Coreg, a lot of times are given at very slow, low doses, 3.125 milligrams PO BID, and the target dose for that is 25 milligrams PO BID. If the patient at 3.125 milligrams in the morning is bradycardic at 40, because this affects alpha and beta receptors, beta 1 and beta 2, you're not going to be able to go up. So you're going to have to, you can't go up. So remember that this is titrated up based on patient's tolerance, i.e. heart rate. So low pressure XR, you start out like 12.5 milligrams per day. The target dose can be up to 200 milligrams a day. And remember, that's long-acting beta blockers. So beta blockers, they interfere with sympathetic nervous system activation. They decrease heart rate and blood pressure, increases diastolic filling, decreases left ventricular hypertrophy, decreases myocardial oxygen consumption, inhibits the release of renin, limiting the activation of the renin, angiotensin, aldosterone. Remember, when the sympathetic nervous system, norepinephrine, is released, it stimulates the renin, angiotensin, aldosterone system. So beta blockers are going to do the opposite. They're going to block that. It's going to inhibit the release of renin, limiting the activation of the renin, angiotensin, aldosterone system. And it's going to improve ventricular function and increase exercise tolerance. So beta blockers are used in New York Heart Association classification 1, 2, and 3. Heart failure with left ventricular systolic dysfunction, used only when clinically stable. They're contraindicated when patients are dyspnea at rest, they've had shortness of breath in the past 6 months, they have asthma and COPD. Now remember, these are prescribed to patients with asthma and COPD. Oftentimes, if they don't have any bronchospasms, and they can tolerate that, but if their shortness of breath gets worse, that's one of the things you're going to be looking at is their beta blockers. Maybe they need to come down or off of them. Bradycardia is a contraindication. Heart block, unstable diabetes, and decompensated heart failure. They're, not stable. Also, one of the other things about beta blockers, carvedilol and toprol, there's a lot of evidence that these medications have prevented inappropriate shock for patients who have an AICD with heart failure. So that's also and implications for NPs. You want to use beta blockers that are approved for heart failure, and that is carvedilol and toprol. Side effects are dizziness, fatigue, hyperglycemia, hypotension, bradycardia, dyspnea, headache, elevated BUN, increased cholesterol, bronchospasm, which they have to come off of a beta blocker, edema, and congestive heart failure. Also, times when patients are on beta blockers, they oftentimes feel really tired when they first are on it. Let your patients know that they when they start this medication, they shouldn't be working, that they should be home, they might need a nap. Things start slowing down for them when they're on this medication, and it is an adjustment. Now, beta blockers linked to diabetes, and the thought behind that is they may modify the insulin receptors where not enough insulin is available. However, more information is needed before it is, we're really concerned. But you might hear that beta blockers are linked to diabetes, and their thought is that they may modify the insulin receptors where there's not enough insulin available. However, again, just like I said, more information is needed on that. So we want to monitor or assess for history of bronchospastic pulmonary disease, routine assessment of glucose levels in diabetes, because again, that can mask the signs of hypoglycemia. Beta blockers blunt the beta effect of adrenaline. So they block typical adrenergic warning signs of hypoglycemia, which are tremors and palpitations. So you have to be very careful. You have to do a lot of education. And again, do not instruct the patients to not stop this abruptly, because this may cause chest pain if they do that. Thiazide diuretic is another medication. The mechanism of action is inhibits sodium and chloride reabsorption. It promotes renal excretion of water, sodium, chloride, potassium, and magnesium. It impairs free water clearance with no effect on concentration. They're less potent than loop diuretics. They're used for symptom control, and they're used in mild cases. Okay? Patients are well controlled. They're not in any acute distress. And renal function is good when patients are on thiazide diuretic and they have heart failure. Contraindications: if patients have a hypersensitivity to sulfonamides, they're anureic, meaning there's no passage of urine. And in practice, this is defined as a passage of urine of less than 500 millimeters of urine a day. Caution: impaired renal function, impaired liver function, electrolyte abnormalities. You still have to check a K when you prescribe this medication. Seizure disorder, diabetes, and gout. If they have start having renal function, you need to switch to Lasix. Side effects of thiazide diuretics are hypotension, low K, increased sugar, increased uric acid, and that you got to be careful if they have a history of gout. This can cause gout, rash, low sodium, low mag, high calcium, and increased lipids. These are some of the side effects. Monitor creatinine clearance. Ineffective if creatinine clearance is less than 30. That's why you have to switch to Lasix. You want to monitor fluid balance. You want to make sure they're getting daily weights. You want to assess potassium levels. You want to be vigilant in the evaluation of potassium if the patient is on DIG. Digoxin predisposes patients, hypokalemia predisposes patients to DIG toxicity. Assess for increased uric acid, assess for increased hyperglycemia, increased glucose. Loop diuretic mechanism of action. These are medications that are commonly used for patients in congestive heart failure. They're more potent than thiazide diuretics. They inhibit the reabsorption of sodium and chloride. They reduce central venous pressures. They reduce pulmonary congestion and pulmonary edema. They decrease blood pressure. They're used for symptom control, and they're very helpful to manage volume overload and reduce preload, which is difficult for patients who have heart failure. Loop diuretics are contraindicated in those who are anureic. They have electrolyte imbalances, liver failure. Caution in patients who are diabetic, who have just had acute MI, arrhythmias, because volume depletion remember, we need a certain amount of volume for the heart to contract and perfuse. So we want to make sure that they're not they're not dehydrated when we give loop diuretics. There's quite the balancing act. Also, we know that loop diuretics can really cause hypokalemia, and patients who've had acute MI are at risk for VFib, VTAC. They're actually, myocardium is very sensitive after an MI. Also with arrhythmias, low potassium can cause arrhythmias as well. Lupus, Lasix can exacerbate lupus, so you have to watch for that as well. And also impaired renal function, you have to watch as well, because this often can cause an elevation in BUN and creatinine. Side effects are orthostatic hypotension, low K, increased sugar, increased uric acid, vertigo from volume depletion, ototoxicity. Lasix can affect hearing with used over long periods of time, anemia or pushed too fast, dizziness, muscle cramps, or blurred vision. You want to monitor potassium loss. Replacement may be required. If you're giving that, if you're prescribing this, you have to watch their potassium, because they might need potassium supplements as well as the Lasix. You want to teach patients how to take INOs and teach the family. It's very important. You want to educate about hypotension and orthostatic hypertension that can be caused from these medications. Lasix can be given from 20 milligrams to 320 milligrams a day in divided doses. Also, there's Bumex, there's toracimide, or Xeroxolin are all considered loop diuretics. Spironolactone is another medication that we give, and the mechanism of action is a potassium-sparing diuretic. It decreases sodium and water retention. It decreases the sympathetic activation. It helps decrease ventricular remodeling, which is that enlargement of the heart. It alters the renin-angiotensin-aldosterone system by effects on aldosterone. It's used for New York Heart Association class 3 and 4. It's used if the creatinine is less than 2.5 and also if the potassium is less than 5. So there's a lot of evidence. It's used there's a subgroup analysis that shows it may help with those who have an elevated BNP levels. It's also recommended in patients post-MI without significant renal dysfunction, in all patients with left ventricular ejection fraction of less than 40%, and those with hypertension, diabetes, or stable chronic kidney disease. But also, it will be added to someone that's on an ACE inhibitor, beta blocker, and they might add this on as the disease progresses and the ejection fraction is less than 40%. Would be an added medication. Spironolactone is contraindicated with renal insufficiency, high K, or use with other potassium-sparing diuretics. So you got to be careful of low K. Side effects are, they can be high potassium with this. I'm sorry, I said low potassium. It's high potassium with spironolactone. And then renal insufficiency, gynecomastia, hirsutism, menstrual irregularities, caution with patients' impaired liver function, impaired renal function, low sodium, or diabetes. And hirsutism is excessive growth of hair of normal abnormal distribution. Initiate dose of 25 milligrams. You want to monitor increases in K, because again, this can cause an increase in K. Monitor for increases in creatinine. Recheck creatinine and potassium in 4 to 6 days after the initiation or increase in dose. If K is greater than 5, decrease dose by half. If K is greater than 5.5, you want to stop the medication. If you can increase dose to 50 milligrams in 1 month if symptomatic and patients have normal K levels. DIGOXIN, the mechanism of action, inhibits sodium potassium pump in cardiac muscles. It's a positive inotrope, meaning it increases contractility, and it's a negative conotrope, decreasing heart rate. It increases contractility, it increases cardiac output, and it also can improve left ventricular ejection fraction. DIG is used in symptom control if symptoms persist despite an ACE inhibitor and a beta blocker. It's helped to improve quality of life, reduces hospitalization. It's also used for atrial fib. Lower levels are used for AFib, and they are effective and safer. Contraindications of DIG are ventricular arrhythmias, heart block. You want to use cautiously in those in renal dysfunction, patients who have heart block, patients with low K because they're at risk for DIG toxicity, those with acute MI, and you want to caution there are many drug interactions with digoxin. Digoxin is not indicated in patients with primary diastolic dysfunction and preserved systolic function. And drug interactions are many with digoxin. A lot of anticholinergics, antibiotics. And serum DIG levels really should be obtained if heart failure worsens, renal function starts deteriorating, medications that are added that affect DIG levels, and DIG toxicity is suspected. So normal DIG levels are anywhere from 0.5 to 0.9. Also, there's a lot of evidence that shows that DIG reduces symptoms but has not clinically shown any positive effect on mortality. And this is in patients with preserved renal function. And the recommended dose is 0.125 milligrams daily. Levels lower are effective and safer for atrial fibrillation. Side effects are arrhythmia, visual disturbance, GI disturbance, weakness, lethargy, and confusion. Beneficial in patients with reduced ejection fraction. It actually has shown to decrease hospitalizations for heart failure. It shows that when they're treated with DIG in 1 to 3 months, it can improve symptoms. It increases their quality of life and exercise tolerance, and in those with mild to moderate heart failure. Watch for signs of DIG toxicity, nausea, vomiting, anorexia, visual disturbance. Monitor DIG levels yearly if no signs of toxicity. Monitor renal function. Monitor electrolytes. Oftentimes also DIG toxicity occurs with lower DIG levels, especially if patients have low K, low MAG, or hypothyroid. Medications like clarithromycin, Multag, erythromycin, amiodarone, cyclosporins can actually affect DIG levels. Also verapamil, including other two. Hydralazine and isosorbide. These are combined medications. The mechanism of action of hydralazine is it reduces systemic vascular resistance, it decreases afterload, it increases stroke volume, and improves ventricular function. Hydralazine is often confused with hydralazine, which the other name for that is atarax. So be very careful, because I've seen some really bad med errors when they've given atarax, when they've given hydralazine versus atarax. So be very careful, they're similar. Hydralazine is an arterial vasodilator. Isosorbide is a nitrate, and these are venodilators. The mechanism of action of isosorbide is reduced ventricular remodeling, smooth muscle relaxation, decreased left ventricular filling pressures, and decreasing preload. So these vasodilatory effects can reduce the intracardiac filling pressures, which most likely reduce adverse cardiac remodeling where the heart gets bigger. Oftentimes you'll see the combination of hydralazine and isosorbide given to patients that cannot tolerate ACEs or ARBs. Very effective for African Americans and those who cannot tolerate ACE or ARBs. These are not in replace of ACE or beta blocker. They try these first. The combination of hydralazine and isosorbide is reasonable for patients who have current or prior symptoms of heart failure and reduced left ventricular ejection fraction, who cannot tolerate or be given ACE or ARB because of drug intolerance, increased K, or renal insufficiency. Hydralazine and isosorbide also may be added to ACE inhibitors and beta blockers when additional afterload reduction is needed or pulmonary hypertension is present. A fixed dose combination tablet has been approved for the treatment of heart failure in African Americans. So the fixed dose of hydralazine is 37.5 over 20, which is the fixed starting dose of that medication. Side effects are hypotension, especially postural hypertension, tachycardia, angina, GI disturbances, muscle cramps, weakness, headache, lupus-like syndrome. The side effects are isosorbide. Hydralazine, just to go back to that, patients can be really severely hypotensive with this, so be very careful. Do a lot of teaching with that. Same with isosorbide. So postural hypertension, tachycardia, angina, headache, dizziness, GI disturbances, blurred vision, and flushing. There are a new medication called Entresto, and this just recently came out in the 2016 new guidelines, which is posted. A new article, it's called Mending the Broken Heart, a nepricillin inhibitor for heart failure, which is the new type of drug. And also, it's called natriuretic peptides and nepricillin. This is a brain natriuretic peptide. The BNP and the pro-B type natriuretic peptide, these are lab work that are gold standard in detecting heart failure and in determining if patients' prognosis and disease progression. So the BNP is drawn, and we monitor it. Does the patient have heart failure? Sometimes we use it for progression of disease, even though sometimes it's not always the best indicator. The natriuretic peptide system in our body is really responsible for the volume and pressure balance. For example, if our body needs vasodilation, diuresis, excretion of fluids, regulation of cardiac remodeling, and anti-hypertrophic actions. So this type of hormone, the BMP, that is released when someone has heart failure, and that's how we tell, because this hormone promotes vasodilation, diuresis, regulation of cardiac modeling. So it also activates the renin-angiotensin-aldosterone system and the sympathetic nervous system this affects the regulatory system and can be seen in the kidneys, the central nervous system, and the cardiovascular system. In patients with reduced ejection fraction, this medication downregulates the renin-angiotensin and the sympathetic nervous system and prevents cardiac remodeling. So what you have is improvement in hemodynamic parameters, better blood pressure, an increase in urine output because there's more perfusion, a decrease in preload, which is less volume coming into the right side of the heart, and a decrease in systemic vascular resistance, leading to an overall improvement in cardiac output. Neprosylin also acts on angiotensin II and bradycardia, and you have to be very, very, very careful. You can't have Entresto, which is the name of this drug, which is a neprosylin inhibitor. You can't have this medication given with an ACE inhibitor. So this is a very important new drug. What I've heard from cardiologists is once they take these patients off of the ACE inhibitors and put them on Entresto, they've decreased their Lasix from 80 milligrams to 40 milligrams. Non-pharmacological treatment, sodium restriction, fluid restriction, diet, exercise, activity, those I can't, like sodium restriction, fluid restriction. Fluid restriction, the evidence is showing it doesn't really do a whole lot, but it is needed for someone who is has low sodium. So, and who is volume depleted and has a really low sodium level. Oftentimes they have to do fluid restriction. Diet, exercise, activity, and sodium restriction are all major teaching, lots of VNA. If you don't do this right, there's going to be a lot of readmissions for heart failure. And as far as what insurance is looking at, how we get reimbursed as providers, we are looking at how our practice is and if our patients are getting readmitted. And this is tough because these patients oftentimes are very sick. So we have to find really good ways to treat them at home and prevent rehospitalization. And this new medication, it's also called RRI, has been showing some great results, and it went through the FDA fairly quickly because the results were incredible. So it's called, this new drug, again, it just came out. It's used in patients with ejection fraction of less than 35%. It's an angiotensin receptor neprosylin inhibitor. So it also has, that's the name of the drug, it has valsartan and sacubitril, which is spelled, so valsartan, also with sacubitril, which is SACUBITRIL. And again, it should not be administered with ACE inhibitors, and they have to be off their ACE inhibitors for at least 36 hours. If patients have any angioedema from ACE inhibitors, I would not prescribe this medication. Surgical treatment, like coronary revascularization, or CRT, which is biventricular pacing or cardiac resynchronization therapy. And this is used to treat the delay in heart ventricular contractions that occur in some people with advanced heart failure. So heart failure means the heart's pumping power is weaker than normal. And what happens with heart failure, the blood moves through the heart and body at a slower rate, and pressure in the heart increases. Some patients with heart failure may benefit from a combination of cardiac resynchronization therapy and also an implanted cardiac defibrillator. These devices combine biventricular pacing with anti-tachycardic pacing and internal defibrillator to deliver treatment as needed. Also, the pumping power in the heart is weaker with CHF, and in heart failure, the blood moves through the heart and body at a slower rate. And what happens is this delays contractions between the right and the left ventricle, and this often occurs with heart failure. So walls of the left ventricle are unable to contract at the same time, and cardiac resynchronization therapy helps that, shown to improve outcomes in patients. And again, this is used with patients with a left ventricular ejection fraction of less than 35%. And most likely the criteria is that these patients have persistent mild to moderate heart failure despite giving ACE and beta blockers. Intra-aortic balloon pump for decompensated heart failure. Ventricular assist device, again, for decompensated heart failure in unstable patients. And cardiac transplant. We want to manage risk factors. Please note, you want to treat the hypertension. It's follow JNC 8 guidelines. Treat lipids. There's all sorts of evidence that lipids are, high statin lipids are wonderful and are showing good outcomes. Again, stop smoking, limited alcohol intake. You want to avoid the use of nonsteroidals, treat sleep apnea, and preventative care consists of flu vaccine and pneumonia vaccine. Omega-3 fatty acids, this is a level of evidence B, has shown reduces mortality and decreases cardiovascular hospitalization with those in omega-3 fatty acids. So that is fairly new evidence, and it's considered evidence B, which is fairly good as well. So drugs known to worsen heart failure, especially those with reduced ejection fraction, potentially harmful and should be avoided or withdrawn whenever possible. Those are we're talking specifically patients with reduced ejection fraction. And this is most antiarrhythmics, calcium channel blockers, except Norvasc, nonsteroidals, and TZDs for diabetics. Actos is an example of that. And that's it for heart failure. Chest pain. 17 million people with coronary heart disease and 10 million with angina. And there's about 785,000 new cases of stable angina occur yearly in patients over the age of 45. 2% of patients, it's higher than that, with acute MI are unrecognized and discharged from the ED. And because this can often be, this is challenging. Chest pain is challenging, and you don't want to misdiagnose. Chest pain, discomforting sensation in the chest area, has a broad differential associated with cardiovascular causes, GI causes, musculoskeletal causes, neurologic causes, psychogenic causes, and idiopathic causes. So the differential diagnoses are GERD, peptic ulcer disease, esophagitis, biliary colic, pancreatitis, pneumonia, pleurisy, mitral valve prolapse, asthma, COPD, acute coronary symptoms, aortic dissection, PE, pericarditis, myocarditis, CHF, rib fracture, costochondritis, and herpes zoster. For women, waist up in women, very important for chest pain. Women can come in with an acute MI and just be throwing up, with just throwing up. That's a differential. Don't think this is the flu or gastritis. Oftentimes, this is their anginal equivalent. Classic symptoms: substernal, provoked by exertion, relieved by rest or nitro. And that's not always. They can have relief from nitro. It doesn't mean it's not, just because they have relief, they don't have relief from nitro, doesn't mean it's not ischemia. Likelihood of MI, pain radiating to arm, neck, jaw, shoulder. They're hypotensive, they have S3 gallop, and they're diaphoretic. Remember, abdominal pain and vomiting. The general appearance, you want to get vital signs. You want to check the neck, respiratory, cardiovascular, abdominal exam, extremities. Look at their extremities. Patients who present with pain that changes with movement should have a musculoskeletal and neural exam performed. And we want to focus on the focal tenderness, muscle weakness, motor, and sensitivity deficits. So good neuro. When they take a deep breath in, does that hurt? Does the chest pain worsen? Is the chest pain only occur with taking a deep breath, or pain on movement only? Are the characteristics? What's the quality, the location? Does it radiate? What's the duration, the timing? What aggravates or alleviates these factors? Are there any associated symptoms? And what would you consider the severity? Acute coronary syndrome has evolved as like an operational term that really refers to a spectrum of conditions that are compatible with acute myocardial ischemia and or infarction that are usually due to an abrupt reduction in coronary blood flow. A key branch point is ST segment elevation or new bundle branch block on the EKG, which is an indication for immediate coronary angiography to determine if there's an indication of reperfusion therapy to open a likely occluded coronary artery. Patients with suspected acute coronary syndrome and high-risk features such as continuing chest pain, severe dyspnea, syncope, pre-syncope should be seen and have an EKG within 10 minutes. Acute coronary syndrome, unstable angina that is no longer relieved by rest or medications, new onset angina, acceleration in angina, which is increase in frequency, severity, or duration, marked limitations of ordinary physical activity, and inability to carry on any physical activity without discomfort. Unstable and non-STEMI or non-Q wave MI. Non-STEMI is shallower and damage only goes into the subendocardial layer. The subendocardial area is the farthest from the heart's blood supply and is more susceptible to this type of pathology. A STEMI is deeper with full thickness, and on EKG there is a Q wave. High-risk patients with unstable angina are often treated with early invasive strategies which involve cardiac cath and angioplasty. Aortic dissection oftentimes presents with chest pain. These are patients with back pain, severe back pain, unequal palpated pulses, a difference of blood pressure pulses greater than 15 millimeters between both arms, and we're talking about systolic blood pressure. Again, patients that present with acute coronary syndrome, we need to get that EKG within 10 minutes. Non-STEMI segment elevation MI, ST segment elevation MI, typical and gradual rise of troponins, more rapid rise and fall of CK and B, which are not used at all in the ER. Often accompanied by Q waves and dynamic ST segment EKG changes greater than 1 millimeter. Signs of acute coronary syndrome, an S3, Gallup, Riles, new or worsening mitral regurg murmur, which is a diastolic murmur. Symptoms include severe ischemic discomfort lasting more than 20 minutes and not relieved by rest or sublingual nitro. Patients complain of substernal compression or crushing chest pain, heaviness in chest that radiates to the neck, jaw, shoulder, or backs. In the United States, more than 25% of all MIs are silent. Women, diabetic patients, and elderly patients have weird symptoms. Elderly often complains of generalized weakness, stroke-like symptoms, syncope, and a change in mental status. Know that a normal EKG does not exclude the diagnosis of acute coronary syndrome and occurs in 1 to 6% of patients. A normal EKG may also be associated with left circumflex or RCA occlusions, which can be electronically silent, meaning nothing on the EKG. In which case, posterior electrodes V7 to V9 may be helpful. Right-sided leads V3R, V4R are typically performed in cases of inferior STEMI to detect right ventricular infarction. Left ventricular hypertrophy on an EKG, bundle branch blocks with repolarization abnormalities, and ventricular pacing mask signs of ischemia. So oftentimes these are if you have a bundle branch block, it's hard to see if they're truly ischemic, and those are tough decisions to make. If we can't make them, oftentimes we have to call the cardiologist. Clinical characteristics of angina. These are them taking good history. What they say is type of pain, most likely to be angina, less likely to be angina, and you can have a dull pressure, less likely to be angina, sharp stabbing, most likely to be angina, 2 to 5 minutes, always less than 15 to 20, onset is gradual, location is substernal, reproducible with exertion, reproducible with exertion, associated symptoms are present, and palpation of chest wall is not painful. Less likely to be angina is painful, exactly reproduces pain complaint, associated symptoms are absent, reproducible symptoms occur with inspiration, less likely to be angina, it occurs in the lateral chest wall or back, onset is rapid, duration is seconds or hours, and again, there's a broad differential, and you have to look at the whole picture before you can make this diagnosis based on this, because way too many patients, based on the data, that this does not exclude acute coronary syndrome. So you have to be very careful. Risk factors are gender, smoking, previous MI or known CAD, huge risk factor. Hypertension, family history, cocaine, diabetes, and high cholesterol. Features not characteristic of myocardial ischemia include pleuritic chest pain, sharp or knife-like pain by cough or respirations, pain localized by the tip of the finger, particularly at the left ventricular apex or costochondroidal junction, pain reproduced with movement or palpation of the chest wall or arms, brief episodes of pain lasting a few seconds or less, pain that radiates to lower extremity. And then, does pain represent a high, intermediate, or low likelihood of acute ischemia? And costochondroidal joints are joints between the ribs and costal cartilage in front of the rib cage. So oftentimes patients can have a cough, but they're also coming in with a fever and pneumonia, and they have chest pain. And the chest pain is due to the cough, and they can point to really where it hurts. It only hurts when they cough. So with that being said, they have none of these risk factors. You know, their vital signs are stable. You've done their labs. You looked at their EKG. The first set of troponins are negative. Now, this pain represents a low likelihood of acute ischemia based on the EKG, based on their labs, positive chest x-ray. This is more likely pneumonia, and I'm going to treat for pneumonia. So that would be the medical decision-making for that. Cardiac enzymes are troponins. Most specific starts to rise in 4 to 6, actually 3 to 6 after onset. First set of troponins we get when they walk in, and then 3 hours later, 2 sets of troponins. The thing is, these can remain elevated for up to 2 weeks. Requires repeat measures in 8 to 12 hours if negative. Troponin has limited ability to detect a late minor reinfarction. There are multiple kinds of troponin, but only one is found in cardiac muscle. With troponin, arise within a few hours of symptoms of onset and typically remain elevated for several days, but may remain elevated for up to 2 weeks when a patient is having a large infarction. And basically, troponin detects cardiomyocyte necrosis. CBK-MB is just not used like it was because the troponins are so sensitive and specific. The same with myoglobin, rarely used, high sensitive but non-specific. So CBK-MBs, myoglobin, are not useful for diagnosis of acute coronary syndrome. EKG. Initial EKG has ST segment elevation in 25 to 50% of AMI. Classic progression over a few hours to several days are peaked T waves, ST segment elevation, development of Q wave, and T wave eversion. That you see with multiple EKGs. So with a STEMI, you have the evolution of a new Q waves greater than 30 milliseconds in duration. And 25% of the R wave amplitude is diagnostic of an MI. Q waves indicate necrosis, dead tissue, and makes the diagnosis of infarction. Significant Q waves of at least 1 square on the vertical axis, which is 0.04 seconds, or 1/3 of the entire QRS amplitude. Significant Q waves indicate the necrosis of myocardial infarction. It should be emphasized that the absence of ST segment or T wave changes does not exclude the possibility of myocardial ischemia, particularly ischemia affecting the left circumflex territory is not always demonstrated on an EKG. So, you got to be very, very careful with that. Take the history, look at the risk factors, and they might need to come into the hospital and get stressed and have a cardiology consult before the discharge. Definition of pathological Q waves: any Q waves in leads V2 to V3 that are greater than 0.02 seconds, or a QS complex in leads V2 and V3, a Q wave of 0.03 seconds, and 0.1 millivolt deep, which is on the vertical axis, or a QS complex in leads 1, 2, AVL, AVF, or V4 and V6, and 2 contiguous lead grouping. So in lead 1, AVL, V6, V4 through V6, or 2, 3, and AVF. R waves that are greater than 0.04 seconds and V1 and V2, with a positive T wave absence in the conduction defect. So you can have marked symmetrical precordial T wave eversions. Those are not significant for an MI, but they tell us that potentially if you have T wave inversions in, say, leads 4 and 5, this could be ischemia. It's not an MI, but it's ischemia, and these patients need to come in. I mean, in the hospital, be admitted. Management of acute coronary syndrome is restore oxygen flow to the myocardium. Supplemental oxygen for those that are have O2 sat less than 95%. There's all sorts of data out there now that oxygen is more harmful. Nitroglycerin and morphine only if extreme pain for acute coronary syndrome. Patients might need PTCA or thrombolysis. Beta blockers to reduce contractility and oxygen demand, which are done on discharge, and also medications like 2B, 2A, which are antiplatelet function medications. So Repro, Integralin, or Aggrastat, or some thrombolytics that are used. And Integralin, you have to be careful. You have to check renal function before you dose Integralin. Nitroglycerin decreases cardiac preload through venous pooling. It's a venodilator. It also causes coronary vasodilation, increased perfusion. You can treat with sublingual or IV nitroglycerin. It's contraindicated in hypertension and right ventricular infarction. Aspirin is recommended for anyone suspected of having acute coronary syndrome. The dosage is 162 to 325 daily. Allergies to aspirin, you want to give Plavix, and it's contraindicated in threatening allergy or hemorrhage. Morphine is used regularly, however, no significant medical trials or research have been done. Dosage is 2 to 5 milligrams IV every 30 minutes is needed or more often, only with really severe pain. Morphine actually has, the evidence has shown when it has interfered with the use of Plavix, and it has interfered with platelets, and it has caused clotting to occur because morphine and Plavix together are not a good combo. So if we cannot give morphine for acute coronary syndrome, that is the recommendation. Beta blockers. Reduce myocardial oxygen demand, contractility, catecholamine derivative, tachycardia, reduce mortality in acute MI and unstable angina. It's contraindicated for those with bradycardia, COPD, hypotension, CHF, and pulmonary edema. Low pressure toprol, 25 to 200 milligrams in divided doses BID, or carvedilol, which is 3.125 milligrams BID. Again, Coreg is a combination alpha and a non-selective beta blocker. It can cause hypotension, so you want to be careful of that as well. Heparin inhibits clot propagation and platelets together with aspirin, thrombolytics, and STEMI. It reduces mortality significantly. Low molecular weight heparin, fractionated heparin, lower side effects. Studies studies suggest it is effective as heparin. Lovenox. Let's see that. Glycoprotein 2B3A receptor inhibitors. Activated platelets bind together through the activation of 2B3A receptors. They inhibit platelet aggregation. Usage is clear in ST elevation MI when patients go to the cath lab. And heparin 2B3A antiplatelets such as Repro and Integralin, and thrombolytics such as Aggrastat. Calcium channel blockers not routinely recommended for acute coronary syndrome. Treat symptomatically. No study showing reduction in mortality. Meta-analysis shows a non-significant increase in mortality rates. They have similar effectiveness to beta blockers and are used as replacement or supplementation. So the medications that we want to use, we only want to use long-acting calcium channel blockers. Norvasc is preferred if we need to give a calcium channel blocker. And Norvasc is preferred to those with lower ejection fraction in heart failure with history of acute coronary syndrome, but initially that's not what we're going to give. That they recommend not giving calcium channel blockers. Again, amlodipine is preferred in patients with low ejection fraction. Cardizem, which is non-dihydropyridine, may cause bradycardia, heart block. It may precipitate heart failure in those with severe systolic dysfunction. Patients with arterial sclerosis, these are some of the big things that you want to give. Aspirin, statins, ACE inhibitors to reduce cardiovascular death in MI. And also second line are ranolazine, which is 500 to 1,000 milligrams BID, which you might see not initially with acute coronary syndrome, but after discharge, especially with those who have ischemia. Ranolazine decreases ischemia associated with calcium overload. It's used with beta blockers, but it doesn't affect the heart rate or blood pressure. A fairly new one in the last 5 years. And that's it for me. We're going to be going over case studies. If you have any questions about any of what I have told or said, please let me know in class. Thanks.